Hi, everybody. Thanks for being here. I'll give a couple heads up. If you'd like to share in the chat box your name, if you have an affiliation to the Gender-Based Violence Consortium and your role, if so, and what state you're tuning in from, just so our speakers have a better idea of who they're talking to tonight. Through the course of this webinar, remember to take some time to self-care. So if you need to use the bathroom or get snacks or whatever you need to do, please do so. We'll ask that you remain muted with camera off during the presentations, but we will have a question and answer time at the end of all 4 presentations tonight. And so feel free to save your questions till the end so that we can answer them.
Welcome, everyone. Thank you for joining us at the Gender-Based Violence Consortium's webinar. For today, just so you know you're in the right place, we're going to be learning about gender addiction and violence victims in healthcare. And so thank you, everybody, for joining us. This event is being recorded. Just to introduce myself, my name is Dr. Annie Isabel Fukushima. I'm an assistant professor in the Ethnic Studies Division. I'm the project lead and co-principal investigator for the Gender-Based Violence Consortium. A little bit about the Gender-Based Violence Consortium. The Gender-Based Violence Consortium goal is to increase public recognition of and deepen public knowledge about violence through research, innovation, and collaboration, the creation of research communities, and enhanced educational efforts. Today's event is part of Domestic Violence Awareness Month 2020. So thank you all for joining us for our events that have been occurring throughout the month. We've also been promoting our collaborator, local community organizers, as well as University of Utah partners and their DVAM events. So welcome all to DVAM, our DVAM event with healthcare providers. If you want to connect with the Gender-Based Violence Consortium, here's some information. I'll later on plug it into chat so you can all see, but a little bit about connecting with us. You can either connect by contacting gbvc@utah.edu. You can also join our listserv where we send bi-weekly announcements of opportunities. And then you can also find us on our website. Something to share with you all is that we will be coming out with a toolkit for educators this coming month. So more on that coming soon. Just a little bit of a reminder of the format for today. We are going to be introducing the speakers. We'll have lightning presentations, and then it will be followed by a discussion. A friendly reminder, Maddie already set this up, but if you have not had a chance to share in the chat, if you can share your name, affiliation, role, and the state that you're coming from, this would be really lovely, just so our speakers know where everyone who's tuning in is coming from so they can better fit the presentation needs to your particular need. I'm going to now hand it back to my colleague, Maddie Grainger.
Thank you, Dr. Fukushima. So my name is Maddie Grainger, and I'll be the moderator of today's webinar. Our speakers will be Dr. Leslie Halpern, Dr. Yoshimi Anzai, Dr. Marcela Smid, and Dr. Kathy Franchek-Roa. We will begin our presentations with Dr. Leslie Halpern. She is the professor and section head of oral and maxillofacial surgery at the School of Dentistry at the University of Utah. She is one of the directors of the Women in Health, Medicine, and Sciences, and she will be presenting on intimate partner violence, an epidemic in our backyard.
Thank you very much. It's indeed a privilege and a pleasure to be speaking with you this evening on such a topic that not only affects us as healthcare providers, but as human beings, to deal with a chronic, sometimes fatal disease process that is occurring globally. Okay, I'm hitting next. Here we go. So if you take a look at the global issues of intimate partner violence, it is a major global public epidemic The World Health Organization lists violence and abuse as one of 3 main health disparities in women. The other is cardiovascular disease as well as mental health. In 2017, the report of the WHO showed that 1 in 3 have experienced abuse by a partner. In the state of Utah, 1 in 3 women are exposed to intimate partner violence during their life, with 42% of homicides that were due to domestic violence, 88% that were a result of a male perpetrator, with 39% as a repeat offender. Utah is also 8th highest in the US with child abuse, of which 80% as the mother as the perpetrator, and 27% is sexual abuse. Many people, think about intimate partner violence, but with COVID, especially last March, it really came to light in Utah with a 75% increase in calls to the police having to do with domestic violence. So Dr. Yoshimi Anzai and I came together and wrote a blog called COVID-19 and IPV, A Tale of Two Pandemics, to take a closer look at what is going on in Utah with respect to this problem. If you look at this problem, you say to yourself, well, is it a big problem? Well, there's an economic impact on violence and abuse. In the United States, greater than $12.6 billion is spent on direct costs, with 4.1 in indirect costs having to do with violence and abuse. In the state of Utah, as of 2017, greater than $92 million was spent on people who have been perpetrators versus $16.5 million on the victims themselves, as well as an increase in human trafficking that I'm sure will be mentioned by my colleague, Dr. Franchek, later on. Well, in terms of being a healthcare provider, intimate partner violence is a dental, medical, and surgical issue. I'm an oral and maxillofacial surgeon, so I take a look at the head, neck, and face. As much as 75% of physical abuse involves injuries to the head, neck, and face. And intimate partner violence, more importantly, has long-term negative health consequences for survivors even after the abuse has ended. Poor health, poor quality of life, and a higher use of health services. In a multi-city review, 41% have been in contact with a healthcare provider prior to their death, while only 3% accessed an advocacy or shelter program. So community healthcare providers are in routine contact with affected patients. So what do? Again, as a surgeon and as a dentist, I have looked at facial injuries and intimate partner violence. In terms of the perpetrator, he or she feels that there's a lot of hitting in the face because a woman's face is the most meaningful area. And I have looked at this quite closely in terms of developing questionnaires that were tested for internal, external validity and positive predictive value to increase the likelihood of women that we questioned showing these particular injuries, along with another validated questionnaire that I'll talk about. More importantly, again, besides the facial injuries themselves, the long-term consequences are with what many of us in healthcare see in patients that come to our office, because they'll fill out a healthcare form that will be extremely in-depth, and you wonder by looking at the person, my God, you don't look like you have these kind of problems. Well, Dr. Jacqueline Campbell's work in 2002 set the springboard for the use of 10 common chronic illnesses to also allow us to more specifically and speaking in specificity and sensitivity, identify more women, their physical effects, mental health effects, and especially the impact of these based upon ethnicity and race. So a typical woman will come into my office that is very well dressed and just something isn't right. So that woman is thinking, why can't anyone figure out why I feel this way, why I am always not feeling well? Why do I have so many medical problems? Not once being asked, was there a past history of a traumatic stress event in relation of an intimate partner violence event? So how can we as oral and medical healthcare providers help? Well, the number one way to help is screening, because studies have shown that abused women want their providers to query them about IPV, asking as a form of intervention. And in respect to dentists, oral health care is most pivotal, looking at The oral health of the individual will allow you to increase the likelihood of identifying them. Now, the Cochrane database, which many of us use in statistics to validate what it is that we're measuring, agreed in 2016 that screening is likely to increase ID, yet rates of referrals are low. So what is the long-term benefit, or what I like to call the so what effect? Well, abusers will often avoid the same physician, but will return to the same dental office because they don't think we're going to look for this. Children are more likely to have regular preventive care in the dental office. And again, as much as 75% of the physical abuse involves the head, neck, and the face. Besides this, we also look to apply other type of diagnostic tools that are evidence-based for identification of intimate partner violence. We want to all say, well, self-report is the gold standard, but we know that there are a minimum amount of patients that are going to come in and admit to you right from the start that they are indeed a victim. So risk factors need to be identified, and then tools need to be developed to measure these risk factors, and we have to look more closely at the so what effect. So we identify what is next, what will we do next that will increase the likelihood to not only identify but avoid future IPV-related injuries. In oral health, there's been an approach called PANDA, Preventing Abuse and Neglect Through Dental Awareness, and this was developed in 1992 by a group of dentists in the Midwest. And many dentists in the community have this course that is given to them by a PANDA trainer. And what it really involves is learning about what the learned behaviors are by the abusers, because many of them have been victims themselves. You look at the patient history, does it match the mother with the child that's being questioned? And believe it or not, you can get a lot out of a child depending upon the way you question them. In oral health, documentation is wonderful because the oral health provider is always taking pictures and we're always taking imaging. And the perpetrator will more likely than not be allowed into the room while we are doing the radiograph. So that gives us time to interview. And also legal and liability. We know child abuse and elder abuse reporting is mandatory, whereas domestic violence varies from state to state, and that is a problem. So utilizing some kind of tools, we try then to take a step back and train people to be able to look at it. Again, in healthcare, we look at dental schools and medical schools, physician assistant schools, nursing schools, pharmacy schools. And the bottom line is to have a recognition in both dentistry and medicine and health that oral health directly impacts systemic health. And it is our role to interact together in an interprofessional collaborative, which is part of what the Gender-Based Violence Consortium is about. There's another model that oral health care providers use called the ABDR tutorial, Ask, Validate, Document, and Refer. And this is available, and you can get that if you want to be able to utilize this tutorial. I've developed protocols when I was in Boston that were utilized with head, neck, and facial injuries and partner violence screen that had good sensitivity, specificity, and positive predictive value. We've done a series of multi-center studies. We're now doing a study on it in Utah to try to get more reproducible results. It takes less than 7 minutes to administer, and we've shown that it does indeed increase the likelihood of identifying the victims of violence. But again, so you identify, what do you do next, all right? So what happens when you identify or refer individuals for intervention? Are you going to improve their health? Can you play a significant role by that initial identification and then apply it to overall health? And the answer is yes. In my former life, before being an oral maxillofacial surgeon, I did a PhD in neuroendocrinology, and I realized the relationship between intimate partner violence and neuroendocrine cascades, because it's the basis of that stress-induced traumatic event that will result in a feedback loop throughout young life into adulthood, where the production of certain hormones will increase inflammatory cascade and breakdowns. And this is why you see the 10 common chronic illnesses. So applying that type of mechanism allowed us to then take risk predictors in terms of certain health exposures. Now, in 2006, what gave me the idea basically to go back to the bench partly, and I used saliva in my studies, was my privilege to serve on the National Advisory Council on Violence and Abuse as a representative from the American Association of Oral and Maxillofacial Surgeons. And this is where I met Kathy Franchek, who will be speaking with you. And that committee's role was to come together as a coalition to take a closer look on how we can both identify, intervene, and reduce future injuries into all victims of all ages. David McCullum and Bruce Ettinger, who were on this committee, developed a beautiful schema called CALIVA, the consequences of lifetime experiences of violence and abuse. And if you look at it as a giant octopus, but every arm out there shows every system in the body that has been shown with good evidence since when Jacqueline Campbell first hypothesized this in 2002, that each system is affected from the stress events of victims of intimate partner violence and violence and abuse, whether it occurred earlier in life or continuously throughout their lifetime. My interest lies in dental, as you can see, and neurological because of the patients that I treat as an oral surgeon, but there are other areas that can show effects, especially cardiovascular, since cardiovascular, as I said, was one of the 3 other global public health epidemics besides violence and abuse. And we've done a study to show that cardiovascular markers for ischemic heart disease are more predominant in women who are victims than age-matched controls. It is a trend, but we're looking at larger numbers right now. So the American Dental Association, the American Medical Association, and other groups have gotten together to develop an ideal strategic plan to see the effects of violence and abuse throughout the lifespan of the victim. And part of that is developing a trauma-informed care collaborative, part of what the Gender-Based Violence Consortium also is going to do in order to visually map patients throughout the state of Utah using different risk predictors in order to develop some type of approach that will decrease risk and increase health-related quality of life. And that is ongoing, as our panel will tell you. So to conclude then, as a teacher and as a researcher, I've seen that there has to be certain strategies. You want to change the learning environment of the community and those that you're teaching. You want to make that education standard and transparent and incorporate it to train younger healthcare providers in all of the health disciplines in order to be able to know how to speak to patients and find out if they are indeed victims. We use role play, for instance. We've invited speakers from communities. We do mock interviews. We have different YouTube movie clips that we show. Patient interactions, of course, is indeed the priority since victims want their advocates to ask. We have to be able to converse with them and find specific risk predictors. One of the type of approaches that I use is I state to the patient, because difficult relationships can cause health problems, we're asking all of our patients the following. Does a partner or anyone at home hurt, hit, or threaten you? Now, it's not the type of questions that you ask, but it is how you ask these questions. The other questions I utilized as part of my protocol was, do you feel safe at home, or do you feel safe right now? Have you ever been hit, kicked, or punched? Or I see that you're hurt, do you want to tell me about it? And I've seen many women in the ED who come in with facial fractures with some stories that you just wouldn't believe, when we all indeed know that they have indeed been victimized. Finally, research. As I told you, part of what I'm interested in my own work is to utilize saliva and blood as certain risk predictors as a baseline, then intervene with my other health colleagues and follow these patients throughout time. So once we intervene, we then improve their health, physical health, their mental health, and we look forward to their health-related quality of life of being improving. So although I spoke really fast, I apologize, I'm from the East Coast, I tend to do that. I hope you can get an idea about what we are doing in oral health and as part of the larger privilege to be on the Gender-Based Violence Consortium. I thank you for your time.
Our next speaker is Dr. Yoshimi Anzai. She is a professor of radiology, associate chief medical quality officer, and adjunct professor of population health sciences at the University of Utah. She is also one of the directors of Women in Health, Medicine, and Science. She will be presenting on searching clues on medical imaging.
Thank you, Maddie. Thank you so much for the invitation to speak. So privileged to be a part of this consortium. I have no financial conflict. I am a radiologist. The radiologist, you may not know, but the medical profession, they're looking at the images and then find out what's wrong with the patients without actually talking to them or seeing a patient. And you may wonder, how could you know without seeing a patient? But actually, imaging doesn't lie. Imaging provide objective findings of something wrong with the patient. So this is practically my kind of clinical experience in the last 6 years at the University of Utah Hospital. And I just wanted to warn you that some of the images may appear kind of sensitive to some people, so be careful. Dr. Halpern talked about, the intimate partner domestic violence is a very, very prevalent. 1 in 3 women, 1 in 4 women, 21,000 phone calls a day for domestic violence hotline. So this is clearly a public health problem. And then when you're looking at the first encounter of the intimate partner violences, surprisingly 70%, over 70% of women encounter first IPB before age of 25. So think about that. Once you have a traumatic experience, there's a whole host of downstream effect of post-traumatic stress syndrome to depression to substance abuse to anxiety disorder, suicidal thought. There's a downstream negative impact, but the first encounter happening at age 25. So when you try to think about educational intervention, the primary prevention, I think we really have to focus on high school or even middle school women to be able to do that. And here's another intersectionality of domestic violences, intimate partner violences for race and gender. So this Kaiser Family Foundation data indicating the huge number of minority, particularly for multiracial, non-Hispanic, African American, and also American Indian, Alaskan Native women are victim of IPB. And this is something that we need to keep in mind. Now, Asian Pacific Islander seems to be lower number, but keep in mind, within the Pacific Islander community, IPB is kind of social stigma. So there's a huge underreporting going on. So this data is as good as they report. So basically, practically anyone can be a victim of intimate partner violences, but particularly for those people who have disability, LGBTQ, military women are really high risk. One thing is very clear is substance abuse. 90% of methadone clinic visitors experience IPB, 90%, 9 out of 10. And also having experienced the IPB led to substance abuse as a part of the coping mechanism. So 26% of IPB experienced person victims have a substance abuse as compared to 5% of non-IPB person. So it's more than 5-fold differences of substance abuse that kind of complicate situations. Pregnant women are also high risk because of the reproductive coercions. And when you think about as a healthcare professional, we think about any condition or disease as to prevention or detection and treatment. If this is a cancer, then prevention could be, eating healthy for colorectal cancer or putting a sunscreen for skin cancer. And early detection could be a mammogram to detect the early breast cancer. For IPP, I think you can think about the same kind of concept. So the prevention, there's a broad-based, public-based targeted education interventions and media messages. So that could be the prevention before something bad happened to the young woman. And then early detection, really, emergency medical technologist or a first-line provider could play a huge role for detecting someone who might be experiencing IPB. And the treatment only happening after the violence has occurred. So it's almost like a damage control or injury treatment, which we all do, healthcare professional. And of course, we wanted to send the victim to shelter services instead of bring it back to the perpetrator. So what we're seeing in the healthcare system is really after patient came to emergency room or trauma services. So that's really the tip of iceberg. And for me, imaging radiologist, I think that patient have to be seriously injured enough for them, the ED physician, the trauma surgeon, to order X-ray or CT scan. So I'm almost seeing a tip of iceberg, but there's so many people underneath it that may or may not be seeking healthcare or may not be seeking a help. So we have to put that perspective. And then not only physical or sexual abuse, but there are so many emotional, financial, child care attachment. There's just so many different kind of abuse going on in a household. But the deep core of abuse is the power and control. So we have to keep that broad perspective. Now, we have studied a long time for non-accidental trauma for children, used to call child abuse. And we didn't know what's the clue, but the study shows there's a definitely clear, specific radiographic sign to indicate this is abuse, injury, including subdural hematoma with different ages, retinal hemorrhage in the eyes or fractures, or some child may be hypoxia. So given that all these findings put together, we can say pretty with a high confidence and accuracy, this is non-accidental, not child didn't fall from the bed. So take that kind of experience. Is there any pattern of injury that is a predictor for IPB? How do we know that because the patient may not be forthcoming as to I am, abused at home. So if we can find the objective findings on the imaging, that could lead it to early detection, and then early detection leaded to early intervention and a reduction of a future injury. So we should learn from the non-accidental trauma model for imaging. And I think we also need to increase awareness of improved documentation in the radiology report. And let me show you some example. Dr. Halpern mentioned facial injury is very, very common among the IPB. We see so many soft tissue hematoma around the eyes and nasal bone fracture for those victims. And again, facial fracture is very common for young women presented with an emergency room that because of punched in the face. And then sometimes you may see subtle little bruise, and a radiologist may not realize, there's no fracture, then we don't talk about it. But I would think we should be documenting any kind of soft tissue injury because that will give you a clue for the future occurrence. Another thing that's very common is upper extremity injury, meaning a hand and wrist, because they try to avoid the face with fist or some force. So this patient had a fracture with the base of the fifth metacarpal, but when you're looking at the additional area, this area had an old fracture too. So it's not just the one. She had a multiple injury, repetitive injury for different ages in her hands and arms. This is a patient, 39 years old, with domestic violence victim and a history of a bipolar anxiety, persistent substance abuse, intoxicated on a presentation. Because when assaulted, a patient wanted to have a medication, but they give you methamphetamine. So it's a terrible situation. You can see there's no intracranial hemorrhage, but they focus blues in the kind of head. One thing's really significantly wrong is 39 years old woman has no teeth. Very poor hygiene. We've seen this over and over. The patient with IPB victim has an incredibly bad oral hygiene and a poor dentition. The patient was kicked in a hip, so there's a dislocated hip on the right side, completely out of the socket with a fracture. So this is a major, major significant injury to the body. The recent article published in 2019, they're looking at the retrospective review of 185 patients with IPB support program and emergency room. This is a Brigham Women's Hospital. And it matched that with other ED visitor, excluding IPB, but age, gender, mass 555 control subject. And then there's sort of a demographics, 96.2% of women and a mean age of 34, and a very prevalent among African American and Hispanic. And a clinical variable including a race, minority, psychiatric comorbidity such as mental illness, and a homeless. Imaging findings that they found in their cohort is acute or chronic fracture of face and skull, and also extremities like a hand and a wrist, and also OBGYN findings, intrauterine growth retardations, or failed pregnancy. So those are the very classic sort of a triad that we see in an IPB victim. And adding imaging findings to clinical or demographic findings significantly improve the area under the curve. So there's some hope for that. Now, in this study, they didn't really talk about strangulations. They only had a 2 out of 188 subjects, which is kind of difficult to believe, but we have a more strangulation in Utah for whatever the reason. This patient strangulated and injured a blood vessel. There's some dissection going on in the blood vessel because of the strangulation. There's another patient, 41 years old, assaulted and punched in the face and is strangulated. In October of 2019, just a few days ago, a year ago, facial fracture, medial inferior with a wall fracture, a lot of air in the soft tissue, so much soft tissue swelling. But when you're looking at the spine CT as a part of the trauma protocol, patient had so many compression fracture. Now, 30 plus years old women should not have a compression fracture. So again, this indicated old injury with new trauma, repetitive injuries, are creating a kind of red flag. On the top of it, when you're looking back the history of these patients, lateral fibular fracture in 2019, and also 2006, when she was only 27, there's another fracture. So every 6 to 7 years, she had a profound injury. We don't know the same person do it or the other person, the different partner is doing this, but there's a repetitive injury in a history that makes you think this is not regular trauma. This is a sad case. It's 45 years old woman that came as a cardiac arrest and a hypoxia, strangulation during the sex, according to their partner, but massive aspiration, and she was extremely hypotensive. A lot of edema on the face and neck because of the strangulations. And also in the abdomen, the intestinal wall is necrotic, meaning there's no blood flow going to the intestine, and there's a portal vein gas inside. And when you're looking at it, this patient had a massive aspiration and a cerebral edema. So this is a very profound hypoxic injury, whether this is due to strangulation or in a combination of drug use, because she had a high methamphetamine dose. So on a drug user, there's a sort of a situation, it's a little complicated because drug itself will give you a hypoxic injury. On the top of it, she was strangulated. In fact, she passed away due to serious illness. Now that sounds like a very depressing. So I want to end with really better cases. 30 years old woman with alcoholism and a status post assault and an ex-husband. She actually had a head bleed. When you're looking at the imaging study, there's a subdural hematoma, big soft tissue contusions. And then later on, the body CT scan, you can see this all sort of bruise. This is all kicked and hit, and then soft tissue bruise on the patient's subcutaneous tissue. There's no fracture, but this is indicating a significant injury. But 6 years later, patient had the healthy baby delivered at age 36 and recovering from alcohol hepatitis, doing very well. And a patient facial filler injection recently, so she must be feeling good about looking good. But some people do recover from terrible, terrible injury. So I think there's some intertwining complex situation surrounding IPB and domestic violences. Definitely the biggest one is substance abuse, mental illness, and also poverty. There's a socioeconomic status is typically lower among the victims compared to normal control. Racial minority, LGBTQ, and also HIV infection also complicate even more for treatment for IPB and a domestic violence victim. So lesson learned, IPB-DB is very prevalent, happen to anyone, but it really starts at a young age. There's a definitely intersection between race, gender, and also substance abuse and mental illness. Repetitive injury, so we need to look into the history to tell us what's going on. Facial injury, upper extremity injury, different ages of injury, and also OBGYN, a failed pregnancy is a very common theme that we see on the imaging study. The findings of the poor dental hygiene, edentures for younger ages, poor self-care, and lack of access to healthcare and also dental care. And probably that also added the risk to the intimate partner violences. But when I see hypoxic brain injury, it's really hard to know that was due to strangulation versus just a combination with a drug use. So we need to document every chronic injury so that we can actually increase awareness. So what do we do from now? The moving forward, we need to have a systematic analysis of IPV domestic violences and different degree of severity on objective findings such as imaging. We need to build a prediction model and then test it, how that works. Machine learning, artificial intelligence to screen subject at the high risk based on medical imaging record would be one thing so we could possibly explore. And also we just need to have a more documentation accuracy that we need to describe all the subtle soft tissue injury. And a communication with the ED provider, trauma team is critical. And also collaboration with the community partner so that the patient can discharge to some places safe rather than going back to the same perpetrator. And also, not to mention, advocacy work to support IPV victim is critical. So thank you so much for your attention.
Next, we have Dr. Marcela Smid. She is an assistant professor in maternal fetal medicine, adjunct assistant professor of psychiatry at the University of Utah, and the general boss of the Substance Use and Pregnancy Recovery and Addiction Dependence, or SuperRAD program at the University of Utah.
I like the term co-grand poobah with Jasmine Charles, the co-director of SuperRAD. I'm going to focus on pregnant and parenting women with substance use disorders and intimate partner violence. As the prior speaker just mentioned, substance use is certainly something that we consider when we're taking care of women with substance use disorders. So I really want to start with what's the role of the intimate partner in pregnant and parenting women who have substance use disorders. And one thing that we really know from the literature is that from initiation into substance use treatment and recovery, women's relationships are really central to their understanding their substance use trajectories. So most women, as opposed to most men, are introduced to drugs by their intimate partner. And often the substance use is central to a couple's relationship and intimacy dynamic. So for example, with folks that use heroin, often sexuality transforms almost into the ritual of preparing the drugs. Often women are being injected by their intimate partner. And so there's very much a relationship dynamic and also a symbolism around the intimacy of sharing drugs and preparing drugs, and that I show you that I love you by only sharing needles with you, and that's a symbol for trust. So that's one thing that we really need to understand in folks who are using substance use, to really understand the role of intimate partner violence. We got to understand the role of the intimate partner. And partner use is the most common temptation reported by women who have drug use. And actually, married or cohabiting women use twice the amount of drugs compared to non-married women. And things that in a prospective study looking at risk factors that are predictive of quantity of drug use. Things that we think of parental family history of substance use, number of relatives that are using, quality of the relationship with other close, intimate people, including friends and close family members. Those were not predictive of the amount of drugs that folks use, that women use. But what was predictive was that marital status or relationship status. And I'll talk a little bit about why those are different. And among pregnant women whose partners use drugs were nearly 5 times more likely to use drugs compared to women whose partner did not use drugs. So an important thing is, just because you are somebody who may or may not be pregnant, but women who use drugs are much more likely to use drugs if their partners use drugs. And then An important thing to talk about in terms of pregnancy is that pregnancy is a really strong motivating factor for obtaining treatment for substance use disorder. But again, we need to understand the role of that intimate partner, and that there can be fear of losing a partner, and that can be a significant barrier to going into treatment. So for example, residential treatment programs are not in this country really set up to take care of families or to take care of couples. So often if a couple needs to, if they both have substance use disorders, there are male programs and there are female programs, and and we're actually very lucky here in Salt Lake City. We have a father's program. We're west of the Mississippi. We have a father's program where fathers can come into substance use treatment, residential treatment with a child, but they cannot do that as a couple. So those are, that's something that's really important to remember, that the way that our treatment centers and our treatment approach is traditionally not been as a family-centered or coupled-centered. Another important thing to remember is partners may actively prevent women from entering treatment. They may not want to be separated. Partners there may be a threat of violence. There may be well, I'm not ready to stop using, then how come you're going to leave me? You know, those types of potentially coercive statements or really physical actions. And then even if a woman does enter treatment, right, and for those of us that work closely in this area, we know that treatment is really quite hard, right? Particularly if someone is in residential treatment. The ending of that relationship, or even that separation from an intimate partner, often leads to distress and can be very distracting from treatment. The flip side, though, is also support from a partner during treatment and recovery can really contribute to long-term maintenance of abstinence, and including a partner in treatment contributes to successful short-term outcomes. So we really have this dual dynamic of, we need to understand the role of the intimate partner in order to understand intimate partner violence. So we did a study here, so now I'm going to switch a little bit to our data here in Utah. We did a study here in Utah in collaboration. It was called the PROMO study with 3 other sites: University of New Mexico, University of Arkansas Medical School, and University of Kentucky. It was a prospective analysis of 80 pregnant women. Actually ended up having a little bit more with opioid use disorder recruited at these 4 sites, each which has a different multidisciplinary clinic for pregnant women with opioid use disorder. And we did prospective collection of all kinds of different instruments, including a HARC, which is Intimate Partner Violence Screening Tool, at baseline and at 3 months. And we also looked at participants' marital status, reported paternal involvement, and drug use at baseline. So I wanted to review a little bit of that data, and this is again our data in comparison to my collaborators' site. So just very quickly, right? So I talked about marital status. So about 1 in 5 of our participants were currently married. What was surprising to me, it was actually one of the very few things that was significantly different across our 4 sites, was that Utah, what looked more like New Mexico, where we had a much lower rate or proportion of women that were reporting being currently married compared to Arkansas and Kentucky. However, there was no difference in planned partner involvement in either their life or the life of the expecting child. And partner drug use, almost about 42% of women reported that their partner did have drug use. It was 50% among women in Utah. And that wasn't significantly different, but again, we have a pretty limited sample size. And then partner opioid use was actually not the most common substance that we had reported. That was either marijuana and alcohol, followed by methamphetamine, and then opioids. Okay. And then we looked also at partner use and maternal medication, maternal use of medications for opioid use disorder and maternal use. So really the overall important message here is that the partner, and it's limited sample, but the partner use did not correlate well with maternal use of medications for opioid use disorder, including methadone or buprenorphine. And that was neither in the past 30 days at baseline or in the past 30 days at our follow-up 3-month visit. So then this is our data looking at that HARC screening, which is a screening tool that we use for intimate partner violence. No difference across the sites, but what's really important here is to look at how high our rates are. So this is at baseline. This is asking in the past year, has a partner or an ex-partner humiliated you? Have you been afraid of that partner? Have you been raped by a partner or an ex-partner? Have you been kicked or physically assaulted? Or have you undergone financial abuse? And so we ranged between 10 and 31% for those, 10% being rape, and highest was financial abuse, 31%. And it was the same across all of our sites, or no different across all of our sites. Okay, and then this, the rate, what was interesting here, we didn't compare this, but we see that the proportion actually decreases a little bit. So this is asking the same group of women, but we have fewer women. So we started with 80 or 78 women that completed this, and now we're down to 55 women because we did lose some to follow up. And we did see, and so we can't really say, is this comparable, because we're looking at two different sample sizes, but the women that did complete the baseline or the survey at 3 months had lower rates than reported earlier, 3% ranging to 22% for those same screening questions. And then finally, what I wanted to quickly review again, this is our Utah data, is what's the role of women who die. So one of the things that we look at in maternal, when we're assessing maternal mortality, is we look at pregnancy-associated deaths. I sit on the Utah Perinatal Mortality Review Committee, and what we found is that drug-related deaths are now the #1 reason that women die during pregnancy or in the year postpartum. And so from 2005 to 2014, over a quarter of our deaths were drug-related, and this has increased. We have now looked through our 2016 data, and that number has actually risen to about 28%, and so we're still seeing it as, and then when we include suicide in there, we're really seeing it. Those are the two most common reasons that we're losing women, reproductive age women, pregnant and postpartum women. And so polysubstance use is the name of the game. Opioids were present in 77% of women who died. 83% of them had at least 2 substances, and 2/3 had 3 or more substances. So we're really seeing an increase in its polysubstance use. So these are women who have died of a drug-related death. And what I wanted to bring up here, and I think this dovetails really nicely with the last speaker, is their mental health diagnoses, right? So 77% of women who died of drug-related deaths had a documented mental health diagnosis in their chart. More than 1 in 5 had a prior suicide attempt. More than a quarter had a prior overdose event. 17% had a prior mental health hospitalization, and then a history of lifetime abuse, either emotional, mental, physical, or sexual, was 1 1/4, and intimate partner violence was 17%. And so the important thing here is we are very sure that this is undercaptured, right? Because this wasn't what I spent a long time digging through all of the charts and all of the available information that we have about these 35 women. And what we don't do is systematically screen. So this is somewhere in a note, and often the intimate partner violence or the lifetime abuse came after death, and that it might be in the police report or in the autopsy report, or sometimes we have information from relatives that happened after they died. So we don't necessarily have that information beforehand, and it really speaks to the fact that we need to be doing the systematic screening when we're engaging. These are all women who overwhelmingly had at least some contact with the medical field. They either had a prenatal visit, a delivery and a hospitalization, or a postpartum visit, and the vast majority of them had all 3. So multiple interactions with the medical system. And really, the deaths here, and this is, this is not specific to intimate partner violence, but what I really like to bring home here is that the deaths that happen to women that have drug-related deaths happen in that postpartum period after a woman has seen often her obstetrician or her OB provider after 6 weeks. I'm sure Maddie has heard this, who rotated with us in Superad, that if you can make it out of the house with pants on at 6 weeks postpartum, you are a hero in my book. book. And this is really when we start seeing women struggling with drug-related deaths. And the 80% of women who died in that late postpartum period versus a third of women who died of other causes. So these are some concluding thoughts. I don't really have conclusions because I think we really are lacking a lot of information and a lot of information about the role of that intimate partner and their trajectory. So we have some information, but we really could use a lot more information about how we can intervene and help women. So the concluding thoughts are really involvement of intimate partners among pregnant parenting with substance use disorders is common. So there are many people that are often surprised when I say, we see partners all the time. They're like, well, your patients don't have partners. We're like, all the time. We see them all the time. And sometimes we're making direct links to substance use care for the partners. We thankfully now, we can refer to Paula Cook and Maddie Grainger, which is really fantastic. But they're there. Even if they don't necessarily show up, we know that they're there. Intimate partner violence is also incredibly common, and negotiating these relationships is incredibly complex. So then my concluding questions are really how, because I don't have answers for this, is how can we best support families struggling with substance use, and how do we best support couples, and what about co-parenting individuals, right? There may be the relationship, the intimate relationship may dissolve, but particularly among pregnant and parenting women, just because the intimate relationship dissolves doesn't mean that the co-parenting goes away. And can you get past violence? What if it's physical violence, emotional violence, financial violence, and how best do you do that? And then are these symptoms, is the violence a symptom of the substance use disorder? And how do you best figure that out? Are people violent because of the substance use disorder? Is this really a part of the substance use disorder, or is this something separate? And I don't have a good answer for that because I think it depends on the situation. So thank you very much. Big thanks to all of my collaborators, as always, Jasmine, Grand Poobah of Super Rad Clinic. Okay, thank you very much.
And for our final presenter, we will be hearing from Dr. Kathy Franchek-Roa. She is an associate professor of pediatrics at the University of Utah School of Medicine, and she will be presenting on the impact of childhood exposure to intimate partner violence and other adverse child events on health and well-being throughout the lifespan.
Well, that's a big title for just a few slides. So of course it isn't a complete topic, but I kind of wanted to set the stage. I'm a pediatrician. So to go backwards in time, instead of looking at the adult, looking at the child. And I'm hoping if we can learn from this, then, Dr. Smid won't have all these drug abusing mamas. Dr. Halpern won't have to do oral facial reconstruction from trauma. And Dr. Anzai won't have to look at all those awful imaging. So I just wanted to point out the fact about trauma, adversity, and stress, because we call all these things the same. But really when we're dealing with children, all of this trauma, adversity, or stress can, of course, become a toxic stress. And in pediatrics, what we mean by toxic stress is one of these experiences, and usually they're chronic, but it interrupts the normal developmental trajectory of a child. And I think that is the most important piece to take away. And even the American Academy of Pediatrics in 2012 introduced what they said is the new basic science of pediatrics, which is the eco-bio-developmental framework. So we're talking about the ecology of the child. And us in medicine, most medicine, we say, what's the social history? Oh, the child lives with mom and dad and they have a dog. Well, that's a nice social history, but that isn't near enough. And that's what we're trying to change, is to understand that. And I think most of you know about adverse childhood experiences, but I really think this is where we need to start, because as you know, this was done in a clinic at Kaiser Permanente in California in 1998. It was published, but they looked at the 17,000 Kaiser Permanente patients who they surveyed, and they wanted to know, what is your experience when you were a child before the age of 18? And as you know, it deals with abuse, physical, sexual, emotional, neglect, emotional or physical, or household dysfunction, which was divorce, substance abuse, mental illness, domestic violence, and incarceration. And And of course, when you have one of these ACEs growing up, you probably have more than one. So it just goes across the spectrum for children. But the most important piece I think here is if you look at from the 1998 study, they said, well, how many had no ACEs? Well, that's 36%. And then you can see how it plays out with how many had 1, 2, 3, 4. But I think the most important piece here is that 36% had 0, then 64% had at least 1. And so I tell my residents and medical students, you know, on average, half the people waiting in your waiting room have had a significant adversity already in their life in childhood. And we're not even talking about adulthood. And it doesn't mean that it might have been a toxic stressor. It doesn't mean that they had their development trajectory interrupted, but boy, it sure is an increased risk that this did happen. And remember, when we talk about the ACEs, it's these 10 ACEs, the abuse, the neglect, and household dysfunction. But as we've all said, this is the tip of the iceberg. And over the years, we've expanded our concept of ACEs and toxic stress. And when we talk about toxic stress, we're talking about all the ACEs, but also other things: natural disaster, death of a parent, community violence, financial hardship, homelessness, racism, sexism, discrimination. And every one of you on this call can give me another one that could interfere with the development of a child. So there is a lot in a child's life and in a family's life. And we have done poorly in medicine in recognizing it and helping them with it. But I think one of the most important things about adverse childhood experiences is they really took you down the pathway to have poor health over your lifespan. So what they found was that trauma during childhood was extremely common. More than half of adults in the United States have had, at least of those surveyed, had at least one significant trauma. And I will tell you, and that's just during childhood. And I will say one of the ACEs is divorce. And you may say, oh, everybody's divorced, no big deal. But when you look at the data, we found that about half of divorces are due to domestic violence. So this is not a trivial thing. A divorce is not trivial. There's a dose-response relationship. The more types of adversity you had, the longer you were exposed, the more likely you are to have experienced high risk for negative health outcomes across your lifespan. The average age of the 17,000 Kaiser Permanente patients who were surveyed back in the 90s, their average age was 57. So things that had happened to them a half a century ago is impacting their health today. And one of the things that I wanted to focus on quickly was when we talk about domestic violence, that of course is one of your adverse childhood experiences. We find that it seems to be one of the most toxic forms of violence exposure for children. There's been many studies now that have, grown from the original ACE study, but looking at domestic violence as a particularly toxic form of violence exposure, studies have found that domestic violence in the home is linked to experiencing multiple ACEs. So your adjusted odds ratio for any individual ACE was 2 to 6 times higher if domestic violence occurred. In other words, if domestic violence is the home, there's a whole bunch of other bad things going on for that child. And the total number of ACEs were increased if there was DV in the home. They found also that domestic violence is a strong adverse experience in and of itself. So if domestic violence exposure was present, that was the major contributor to poor health outcomes across the person's lifespan. And we know that one of the most important ways that it affects health is the adoption of high-risk health behaviors. So the women who are doing drugs when they're pregnant, this is one of the things that when I was a young doctor, I have to say I'm ashamed of myself, but I really felt, what a horrible woman. I don't care if you do drugs to yourself, but to do it while you're pregnant is just horrible. And thank goodness that just lasted just a little bit in my early years. Now, I never said that to a patient, but you got to know if I was thinking it, a patient was sensing this. But as I learned about this, I learned, the stories I've heard from women is just like, man, I'd be doing drugs in a heartbeat. And what this has really taught me is to be empathetic, non-judgmental, and how to really manage a situation that gets out of control. And one instance is when I attended the Well Baby Nursery at the U, and the residents were telling me about a mother who was using drugs during her pregnancy, but when she found out she was pregnant, she stopped. So as all of you know, the drug abuse during pregnancy is a major deal. Babies can die if they go through withdrawal and we don't know about it. We're not taking care of them properly. And that's why the Super Rad Clinic and those physicians that are involved in it are my heroes. But I remember so we go into the room to talk to the mama, and I said to her, the residents were telling me that you were using drugs at the beginning of your pregnancy. And the mother just freaked out. I know, I'm so sorry, I didn't mean to, I didn't know I was pregnant, and it's just going crazy. And I said to her, because I had learned about ACEs, and I said, listen, I know that life happens, and sometimes you got to use drugs to get through your life. I understand. But I said, what you've just shown to us is what a good mama you are, because you stopped doing drugs when you found out you were pregnant. And what she did was that anxiety just went away. And now I could talk to her about her baby. And I will say to you, my husband always says it's all about you, Kathy. I go, yes, it is, because in 30 seconds, I had that mama where I needed her to be so I could talk about her baby. I can't talk to her when she thinks I'm judging her, when I'm not understanding. So it makes our jobs much easier when we understand this. Victimization and perpetration. We know that children who witness violence in the home against their mother are more likely to perpetrate or be victims in adulthood. And the other sad piece of this is this synergistic effect that domestic violence has with other forms of the ACEs, is that if domestic violence is present, with numerous ACEs, 1 + 1 doesn't equal 2. 1 + 1 might equal 5 or 10 or 20 because of this synergy. And when we look at children, what do they look like to us in the clinic? We know the developmental, because that's makes it a toxic stress. It interrupts the normal developmental trajectory. And I just want to take a minute to look at our teens, preteens, as they're going through back into school now. I cannot tell you how often we hear, well, he can't focus, he can't sit still, he can't concentrate. So that's ADHD. Well, is it? I mean, if your brain is all wired differently because you've been traumatized repeatedly, chronically, do you think you're going to be able to sit still and listen? Do you think you're going to be able to stay on task? Do you think you're going to be able to complete your work? What does that say to everybody who doesn't understand trauma? Oh, this is ADHD. And I will say that giving a stimulant to a PTSD brain or a traumatized brain is not good medicine. And also, all of the years I have doing this, every single time a parent has said, Dr. So-and-so diagnosed my child with ADHD, but the medicine doesn't work, I say, then it is an ADHD, because simple Ritalin salts works. Now, and so what I have found it to be every single time is domestic violence. And why? Because I ask. Now, I'm not saying kids who are traumatized can't have ADHD. They certainly can, but you sure don't treat them with a stimulant until you get the PTSD or the other trauma under control. And of course, this goes across their lifespan. One of the things I just want to finish with is the idea of the medical field recognizing trauma across the lifespan. Because as you recall, in 1962, C. Henry Kemp published that paper in JAMA called The Battered Child Syndrome. And people were just amazed that parents could viciously abuse their children. It just was beyond our comprehension. Then in the 70s, with the battered women's movement, women said, just because you're my husband doesn't mean you can beat me up. Then in the 1980s, that was when the healthy people decades began, because the Surgeon General said, holy cow, violence is an epidemic in our society. But everybody began to study these in their own silos. The child abuse people didn't talk to the domestic violence people. The domestic violence people didn't talk to child abuse. They didn't talk to the battered society people, the community violence. But who connected that? The ACEs. The ACEs, all, because in almost or many of the situations, if you were violent as an adult or a victim as an adult, you were set up to be that way as a child, or at least you were exposed to it. And to finish then is, what do kids need the most? That was my little alarm, Annie, to tell me to shut up. So I'm going to shut up. But what do kids need? Children are going to be traumatized. I can't help if a tornado destroys their home, right? That's horrid. I can't help COVID, and it's causing such such destruction in our social and our mental psyche. But what is the most important thing that can happen is a relationship. And this is proven over and over and over again. So we can put this up later too, Annie, but I just want people to know we have a wonderful resource. DCFS provides funding for domestic violence, counseling, free funding, and this is not only for victims, but also perpetrators. But if you need more information about it, so you can help your patients, let me know and we can put this up later. So I just want to thank you for this opportunity, and I'm looking so forward to hearing questions because I got a bunch too, but I hold mine back. But I'm looking forward to hearing from all the rest of you.
Okay, thank you, Dr. Franchek. So I'll now open up the webinar to questions from the audience as well as the speakers if you would like. We ask that you can either write your question in the comment box or you can send it directly if you'd like to privately to Annie Fukushima or Maddie Grainger. You can also raise your hand using the raise hand option in the participants box in Zoom. If you'd like to ask your question in person to all the speakers or any one speaker specifically. To start off the question session, I have a question for the whole panel if anyone feels particularly inclined relating to the LGBTQA population specifically. Multiple of you speakers brought this up as a contributor to the relationship between intimate partner violence, substance use disorder, domestic violence in general. Dr. Anzai noted that 26% versus 5% of substance use disorder patients had experienced intimate partner violence versus not. Dr. Smid brought up that married and cohabitating women tend to use 2 times the amount of drugs, and that 25% of pregnancy and drug-related deaths had lifetime use. And then Dr. Franchek mentioned the synergy of all of these contributing factors. And I'm wondering if any of these statistics or other experiences as providers have given you any insight into the LGBTQ population, maybe barriers that these populations face to accessing or receiving care, or how substance use disorder and addiction has affected these populations differently.
I would just like to say real quick, because I'm not the expert. I think I've got experts on the panel who are, and those in the audience, but I will say this goes back to relationships. And when you have, I mean, we see children, teens in our clinic who are, you know, because we always ask, are you interested in boys, girls, both, neither, whatever? And we're getting more and more saying, well, I don't know, or I'm interested in, if you're a boy, I'm interested in boys, or if a girl, I'm interested in girls, but my parents don't know, and I don't want you to tell them. And I mean, if you don't have that relationship, you know, in your own family to help support you, you're already going down the road. So I think that is the important key here, is that good relationships with adults in their lives that really matter, for adults also.
I just wanted to add it on, the LGBTQ is definitely a high risk for IPV or domestic violences. The 40% of lesbian, 60% of bisexual women are victims of IPV, as compared to 1/3, so 33% or so for non-LGBTQ women. In terms of transgender, I think that there's a challenge for access of care. Many transgender persons do not seek medical care because the fear of mistreated by healthcare professional or staff member. So we really need to have a more healthcare professional education. How do we take care of a patient with the LGBTQ community? So Marcela may have, Dr. Smid might have a more insight as to drug usages among the LGBTQ patients.
Now, I don't know whether my colleague wants to answer that first.
Go ahead.
Okay, thank you. I just attended a national sex and gender in health education summit, and what my colleagues are saying are indeed the truth. We have to be trained in order to learn how to question the patients and make them feel that they are in a safe environment. I can tell you from my own experience that I learned more about same-sex abuse when I did a TMJ fellowship in a very structured environment that did not appreciate LGBTQ populations in their community. But I noticed a dynamic of a control that was more subtle, interestingly enough, than the control that I would see with heterosexual couples that I would interact with. So I think we really need to develop a new curriculum to learn how to question our patient population.
I will just add that just because someone is pregnant does not mean that they're not LGBTQ, right? And so one of the important things, and I think this is certainly something we try to be sensitive to in SUBRAD, is that the person, that there may or may not be a father of the baby who is known or will be involved. And often LGBT, we know certainly from the broader population that LGBTQ women in particular are at increased risk of sexual assault that may result in a pregnancy. And so not assuming that the pregnancy was wanted or desired, and really what are all of the options that this woman has. And then also not assuming that their partner there may be a biological father of the baby, but that may not be their intimate partner. And the sex of the biological father of the baby, who's generally male, may be different than who their intimate partner is. And so I think we try to be very sensitive to that. But we also, we are an evolving thing, and we try to be as sensitive as possible. But it's certainly things that I think in an obstetrics clinic, there is lots of assumptions about people's sexuality since they are pregnant, but that's not an assumption that we should always make. We should never make, really. We should never make it.
Absolutely.
Okay. And I guess I will ask another question in case anyone else is forming theirs. In terms of targeting prevention in healthcare, I'm wondering, and some of you touched on this a little bit, if you can speak to substance use disorder specifically as a contributor to instances of intimate partner violence, and if you have noticed either in data or in your own practice, like biased statistically, if you notice a chicken or egg, if one comes before the other, or if it even matters when targeting prevention.
Mm-hmm.
I can at least answer certainly from I think that, Maddie, what the nail that you're hitting, right, is that I think it's very hard to distinguish between substance use disorder and intimate partner violence and which one came first. Certainly, as Kathy was mentioning, that there's a long history of often domestic violence that women that we take care of witnessed as children. So when did that start? Often a relationship that may not have been, like, I think there's some women that don't necessarily, if you ask them, have you been a victim of intimate partner violence, right? They think, did someone hit me, right? But I think or have I been raped? But when we ask those, why we specifically ask things like financial abuse, right? Has somebody held finances against you? That was our highest, right? Specifically in our population, right? And then when you really conceptualize that as violence, right? Then I think women say, oh, that, yes, then in that case, yes, if you're conceptualizing it as that. And when you're tying the role of the substance use, right, to finances and intimacy, it all just gets, I don't know how to necessarily tease that apart. I think there are research methods that could, but I think it's going to be bidirectional.
I completely agree. I think it's very difficult to know which one comes first, but I know that some situation, the partner, kind of like controlling by forcing drug or doing things illegal. And I think that's the kind of beginning of the forming a relationship, and somehow women are forced to or coerced to, do things that it's perhaps not right things, but that could be the entry point. As the Dr. Smid mentioned, the sharing a needle, it's kind of like some sign of intimacy or commitment. And I think that kind of perpetuating a downstream effect of being addictions. And many women that come to emergency room regular basis really have a polysubstance abuse. So it's not just one drug, but it's a multiple drug. And in that creating a more poor health because of that situation. And I think it makes it really difficult to treat the medical condition because there's a polysubstance abuse on the top of strangulation and injuries and fractures and all the other medical conditions. So I think it's really hard to tease out, but a statistic show that methadone clinic visitors, 90% of them are IPB. That is really a striking number that are perhaps definitely increasing use of substance abuse potentially because of the situation they're in or as a part of their coping mechanism. I don't know.
In relation to what both of you had said, what has intrigued me and what I've seen are things that all of you have brought up, but most importantly in pregnant women. Looking at the poor dentition in pregnant women, one thing, Dr. Smid, I'd like to ask, have you seen decrease in weight of women during pregnancy instead of increase in weight? I have seen this in pregnant women that I've treated during the second trimester, since that's quote unquote the most ideal time to treat someone dentally when they're in their second trimester. But what I've noticed with many of these women who I've known before they became pregnant, that they look thinner, that their dentition is quite poor or missing. And I'm kind of wondering whether the OBGYN community is starting to use this as risk predictors during the pregnancy to try to catch something before the end.
Well, I will say, full disclosure, I am the daughter of a dentist. So we look a lot at teeth, and I know we talk a lot about dental health, and you're exactly what you're talking about, right? Like, how can you get high quality protein if you can't chew, right? And I mean, we see our women that just have little nubbins of teeth, right? And I wish I could say we are more systematic about talking about nutrition, but often we are trying to get them into you. And really what we struggle with is really insurance coverage and getting them in. They have to have the right insurance to be able to see our dentist, to get them into clinic, then to be like, yes, please treat them now, not postpartum. They're going to lose their dental coverage when their Medicaid switches over to not pregnant Medicaid. Please, please, please treat now. So we love the dentist. We would love you to treat in pregnancy. We will give you every letter on the planet. But I do think that it is, I think it's recognized that poor dentition is a risk factor for poor obstetrical outcomes, for poor weight gain, and certainly in our population who have some of the most horrific teeth, right? We are often doing a lot of begging. Please, please, please do this now.
I think one of the big factors is really socioeconomic status. A lot of IPV victims have a low income population on the top of underrepresented minority might have lost a job or employment during this COVID-19 pandemics. But it's really access to healthcare, access to dental care, it's extremely limited. And that really led to poor dentition. 39 years of woman was edentulous. That should not be happening if you have a normal life.
Okay, it looks like we have a question from Jamie Troyer, if you'd like to ask.
Yeah, so I'd like to ask Dr. Franchek, it really stood out to me, the slide where you said, is it ADHD or PTSD with children? And with us working on the primary prevention of intimate partner violence, just asking, has there been any data or studies across the adult lifespan of those that continue to be diagnosed with ADHD and they're not, again, they're self-medicating maybe with illegal substances because, again, the regular medication doesn't work. Has there been any studies that kind of correlate to be in primary prevention? Can we look for this red flag, or when we're talking to people, especially since we're trying to stop the perpetration. You know, and men, if they're coming into a clinic or doing something like that, that we can correlate anything like that. Is there any data or anything on that?
That is an excellent question. And I don't know about the adult data on ADHD. I do know we have more and more information about ADHD diagnosed children have have a higher risk of having been traumatized. So that's starting to come through. I don't know. I would say to you that if you've got an adult with ADHD, you know, remember we started to, when 20 years ago when I was first learning this, they were like, you know, ADHD doesn't go away when you become 18, yet we don't even talk about it in adults. And I think a lot of it is because adults have learned now how to deal with it. They also don't have to sit in a classroom for 8 hours a day. You know, they kind of pick jobs that they can function in, et cetera, et cetera. But now as I've learned, and I think that's probably part of it, but what I think about attention deficit hyperactivity is I just have seen so much of it over the years, and it is always trauma. And so I would say to you in the adult world, which is, I'm sure there is information about it, so that would be something I should probably look up into. But I would say if you've got an adult with ADHD who's still having a lot of problems dealing with it, I would have to really step back and say, tell me your story, you know, tell me where you came from, what's happening to you now. Do you want to talk to me about it? I would really go there, because if you want to help their ADHD and they've been traumatized, you can't do one or the other. You got to do both. So I think that's an important point, and a really, really good question. I'm really interested in ADHD because I get it all the time. So I may look into that literature in the adult world about adults with, you know, ADHD symptoms. Thank you for that question, though. Oh, one other thing I will say, though, is talk about prevention. You know, one of the things I think is so important, you know, we've talked about this before, there's primary, secondary, tertiary, but I think one of the most powerful things that we can do right now is partner with our OB-GYNs, with our family medicine, and get these women when they are pregnant, and the young men and women who are starting a family. Rarely do people say, you know, this is the best time to grab them. They usually will go get care, right? So an OB-GYN or a family medicine who does it is seeing them over and over again during their pregnancy, and start to talk to them. I don't think you have to say, what are your ACEs? I think you should start to talk to them, or just give them a little information on what are adverse childhood experiences, how that might affect people in their relationships, how it might affect them parenting. And I think this could be a very powerful way, because we know education is probably the biggest key. And so that was one of the things that we're kind of starting to focus on, even in my clinic, where we can talk to parents about that who have young children, start giving them that information. Thank you.
So it looks like we have a couple questions in the chat, and I'm going to try to kind of combine them because they look relatively related. So one is, can you speak more on how emotional and psychological abuse has on the impact on health problems, and then also in the absence of physical violence? So how does emotional abuse lead to poor health outcomes, and how does abuse how does emotional abuse lead to poor outcomes in the absence of physical abuse, and how does that relate to poor health outcomes?
You know, I think I'm going to let my colleague, Dr. Halpern, my neurobiology colleague. I didn't even know you did that, Leslie. That's incredible. But what I want to just say about the emotional abuse is, you know, we call it domestic violence, and that implies I assault you, but we forget about the psychological and emotional. And I'll tell you, the survivors who help me teach my residents, one of them in particular will say, you know, my broken bones have healed and my scars have faded, but the things that he called me, I cannot get out of my mind. Mm-hmm. And sometimes when she talks to my residents, she cries, and sometimes she doesn't. And this was 30 years ago. Now, I'm not saying this is 30 years ago, so get over it. I'm saying, wow, this is 30 years ago. And the physical assault is not what is giving her the nightmares. It's the psychological assault. So I'll let others talk more about the neurobiology of that. But I think that's I'm glad somebody asked that, because I really think we need to we need to not belittle the psychological emotional abuse.
Yes, I think that the psychological and emotional abuse is collateral damage, if you don't mind me using that expression. And I can tell you that any stress-related event, especially when you're a child, feeds back in your brain and starts the wheel rolling. That can either go in one or another direction depending upon the repeated exposures of the emotion and physical abuse. And I came across this quite interestingly with a term that somebody in the audience will know when I say it, called secondary victimization. And when we talk about training people on how to question victims, especially I've run across this with my dental students and my medical students that I mentor, many of them are very resistant to learning how to question victims because it brings up something that happened in their own life that they have shut away. And many doctors and ancillary health staff will admit this when they are questioned in focus groups. But I can tell you that our body is so uniquely programmed with hormones that all you need is one aspect of this feedback that I showed you to set off a series of irreversible events. And that's why, as adults, and my primary care providers in the audience and my colleagues in my profession will agree, that you can see a health history on a woman from a very high socioeconomic background come in, and again, what is wrong with me? And I would say that violence and abuse is not just a low socioeconomic risk predictor, it is across the board. And it comes up when you least expect it. So our intake of what is happening in our environment is what starts the ball rolling. So the emotion and the psychological insult feeds into it.
Okay, and to follow up on that topic, another question is, what are some of the protective factors for resiliency for women struggling with addiction and intimate partner violence? And I'm also going to expand that to not just women, but to anyone, including LGBTQ communities, and maybe Johanna Greenberg can chime in with her ideas in that topic.
It looks like Greenberg left.
Okay, so then maybe anyone on the panel can speak to some protective factors with both intimate partner violence and substance use.
I just want to say that there is a document called The Essentials of Childhood, which again talks about safe, nurturing relationships with children. And that, I think, is the most protective factor of going down the road to becoming a perpetrator or victim. Now, it is true, anybody can be a victim. I can't control what someone's going to do to me, but the damage that it does to you may be a factor of you being more resilient because you've had loving, nurturing relationships. And we know there's genetic factors in resilience. I think that the next explosion in research now is going to be resilience. Why can I have 4 chronic ACEs and I'm a drug addict in the gutter, where you can have 4 chronic ACEs and you're a physician or a surgeon? Why? And I think that that's the big question now. And we know some of that answer, but I think that's where we need to be going. But we have a lot more information about resilience now. But I'm going to get off so that the others can.
I mean, I will echo that, strong family relationships, even in the presence of adverse childhood events that were perhaps perpetrated by a parent, having a strong relationship that is current is a protective factor for going on to be a perpetrator. In terms of substance use, I think, I mean, that's a hard one, because I think we can do the litany of things, but we really don't understand what is it about what is that key thing. It's probably not one thing, right? We're all complex social human beings that you take the same person and you put them in a different environment, the outcome could be very, very different. And fortunately, we're not rats, right? We don't get to have that experiment. And so really distilling it down to that one key thing that I wish we could package and be like, here is your resilience magic bullet, right? We just don't know what that is. And so I think what I would love to reshape the conversation as is, how can we be a more, as opposed to how can a person be more resilient, how can we create communities and systems of care that make it so that all types of people can thrive, right? And so I think that's the point of these panels that I love, is that it's not just about asking the person to be an individual, it's how can our healthcare system and our communities and our social services and our schools and our social work, right? How do we create those systems that don't ask people to have to be the weed that grows up in the middle of the urban jungle? It's really, how can you create a garden in any environment and really utilize the resources that is available there?
Yeah, I completely agree. I think sometimes the incredibly established person had a hardship, the tremendous injury, and it's not everybody becoming a drug addict and an IPD victim. So there was something that, I don't know, that's a personality or characteristics, or some strengths, internal strengths, or maybe perhaps there's some emotional support after the traumatic event. But there are people who thrive, in fact, after the hardship. And it's not like I agree with you, we shouldn't be just living to the individual, but I think we shouldn't be saying just because you have an ACE, you're gonna have a downstream life that's just given. I think it is an opportunity to come back from the hardship to really becoming a more, being a meaningful, part of the society. That's what I wanted to believe.
Yes, I have to agree with my colleague. I think it really lies in being able to communicate, to develop a communication strategy across the board. Because, we look to our own colleagues to solve certain problems that we can't. But I know with myself, it's only recently that I have colleagues who are involved in this trauma-informed collaborative to develop tools to increase resilience. And it's not easy. I mean, as you said, some people can survive a traumatic event and some people can't. And you wonder why. I think it's all about listening and developing some type of language. I believe that there's a language that can be developed.
Okay, so I think we're gonna wrap up the question portion. If the speakers would like to leave us with, a final statement or their best recommendation for their field, and then we'll kind of wrap up.
Well, since I was the first speaker, I'll say the first statement. As what the title of my talk was, intimate partner violence is an epidemic in our backyard. And I don't think any of us should ever judge a book by its cover in the patients that we take care of. I think we need to learn how to communicate with our patients. And that is something I think that healthcare now is working on. What is the new language to be able to communicate, to help identify more victims, to intervene, and give them a better health-related quality of life? And that's what we're working on now.
So I would echo Dr. Halpern said, but it's really multi-stakeholder involvement is critical, just like prevention to early detection to treatment. community partner to healthcare worker to social worker. Like we need a lot of different kind of diverse groups of people to attack this pervasive, terrible public health problem. It's not just a one size fits all. Everybody has a different type of trauma, different type of injury, any manifestation and health outcome. So I think we need to have a very broad spectrum of approach to address the intimate partner violences.
Okay, in the order of speaker, I think for the intersection of substance use and intimate partner violence, particularly among the population that that I take care of, I think it's asking questions and asking, opening the door to saying that this is something that does affect your health. And even if someone, I get asked a lot, well, what if people don't tell you the truth? Well, by asking the question, you have demonstrated to someone that you're interested in the answer, and they may not be ready to tell you now, but they may tell you later. And that's certainly been something that Jasmine and I have seen, that we have taken care of women throughout their entire pregnancy, but it wasn't until their postpartum visit that we finally hear about the intimate partner violence. And that's when we really can do it. But it's because we ask the question that we open the door. So I think asking the question and being prepared for the answer, but also being prepared that people might not be ready at that moment. And that's okay, that the door should be open.
And just to finish up, thank you, Dr. Fukushima. This was great, and thank you, Maddie, for helping this, organizing all this is great. I think you're right. All of us have to do all types of prevention, primary, secondary, tertiary, because that's what we're seeing all across the board. But I think we have to, if we don't put the money into primary prevention, we'll all have jobs forever, right? Because they will need us, because this will never go away. So the primary prevention, and you know what? That starts with who? Us, the pediatricians and the family medicine docs. So we've got to start talking to families about that. And Dr. Smid, I think this is great, because that has been my message all along, is I don't have to know that what happened to you, and I can still help you. And I help you by making my clinic a safe place for you to come, having resources for you, starting the conversation, giving the education. And I think that that is what really starts people to understand that this doctor or this healthcare provider or this system is somebody that I can go to because they care and I can trust them. So thank you for that.
Well, thank you, everyone. I want to thank Maddie for being a wonderful facilitator. And please do stay connected with us. I put in the chat our link to our website, as well as you can contact GBVC at utah.edu to join our listserv, to stay connected. You can also contact these wonderful doctors directly. They are very busy folks, so be compassionate, empathetic with their energies and time. And I want to thank you all for your wonderful presentations.